Well, good afternoon and welcome. Thanks for joining and making time out of your day to spend with us. Today we'll be talking about how in-workflow surgical CAPD, computer-assisted physician documentation, impacts physicians and hospitals, both quality, documentation, and revenue. I'm Karen Landon, Director of Solutions Marketing with Nuance, and I'm pleased to have you here today and enjoying the session. We understand the challenges you face each day improving the quality of care you offer your patients and your community, and doing so with efficiency while also managing costs. We're pleased to share with you an approach to engaging your surgeons in a better documentation experience for improved quality care, communication between care members, and then resulting in more accurate reimbursement for your organization and for the physicians themselves. You may have seen that recently Nuance has announced an expansion of our artificial intelligence and documentation for physicians through a partnership with Vincari as one of the leading solutions for surgical documentation. We're really excited about that partnership and to share the solution that we have with you today. I'd like to go ahead and introduce our key speaker. Welcome, John O'Neill, who is the Vice President of Strategy and Business Development with Vincari. He has over 30 years of executive leadership experience at the healthcare level, previously affiliated with Ascension, St. Vincent's, and Our Lady of Lourdes Memorial. Welcome, John. And also with me today is Michael Damrich, who's a physician specialist and creative director with Vincari. Together, the three of us will present the content to you and make available to you the slides at the end of the presentation, as well as a recording of the solution of the session today, and manage a question and answer session at the end. So let's talk a little bit about our agenda. So first, we'll talk a little bit about the problems that we solve and why we've brought this solution to market. And we'll transition to the value from an executive's perspective, where John will share why creating a better surgical documentation process is really a strategic imperative for your organization. We'll take a closer look at the solution and how we've brought it to market and what our approach is and how easy it is for surgeons to use, and then we'll manage Q&A. Throughout the session, you can ask a question by clicking on the Q&A button at the bottom of the console, and then we'll address them live at the end as you enter your questions in through the Q&A chat box. So let's begin. So what are the problems that we're trying to solve? It's our belief at Nuance and Vincari, and it's been proven that using artificial intelligence to help support the surgeon, to unburden the surgeon from some of the traditional difficulties with managing documentation, is a way to scale and drive better efficiency and outcomes for your organization. We've brought the solution together to market to address three main challenges. Number one, the rules around clinical and surgical documentation are constantly evolving. As the rules change, it's hard for physicians to provide consistent information and to know how to answer the questions that are being asked of them. In many cases, they don't even know what questions are being asked of them, but yet they need to include that in their clinical documentation. We wanted to develop tools that at the point of care, no matter what the situation is that they choose, certain procedures and the appropriate questions will be asked of them at the right time. We help make it really easy for the physician to capture information while they're thinking about it, while they're in the patient record, while they're thinking about the patient's care and treatment, and satisfy those questions that are typically asked later in the process retrospectively by coding and eliminate that from the process. The second main problem that we're trying to address is that surgeons waste an extraordinary amount of time on repetitive tasks. We hear from our client users all the time that their traditional documentation process feels like Groundhog Day every day. The systems don't really learn their habits, and they need to start from scratch every time. It's hard to capture the patient's real story as well. So our solution has been designed by surgeons for surgeons to leverage the physician's information in their own words and the way that they describe things, as well as any other information that we can leverage from the chart to fill in holes and missing components of the documentation that better round out the patient's story, like existing diagnoses or scheduling information to make the physician more efficient at the point of care. And then lastly, we want to make sure that downstream care and coding teams who depend on the timeliness of that information have good quality details in their hands as soon as they need it. It's important that regardless of the EMR, the hospital and the physician practice is using, that information is readily available to them. Once the physician completes their work in Vincari, and you'll see this through the demonstration and the discussion today, that information is immediately sent back to the record. So the care team, the team in recovery, as well as coders, CDI, and the physician's practice has everything they need to know to take care of that patient and to finish their job. Interoperability is also extremely important to us. This is an IT light implementation that leverages existing ADT and result feeds to make it easy and fast to get up and running. And we'll talk more in detail about that as well. So with that as a backdrop, let's turn to an executive's perspective on why capturing higher quality surgical documentation is really a strategic imperative for your organization. John?
Good afternoon. It's my pleasure to be with all of you today. And as they mentioned, I have been in healthcare for about 30 years. I am a retired and recovering CEO, and I've worked in small hospitals, and most recently was with St. Vincent's in Birmingham, which we had about 900 beds and had about $2 billion in gross revenue. So what that really means is that I've probably been in every situation that you're currently in, and I've done some things well, and I've made a lot of mistakes. But I've learned a great deal since I've been able to sit back and really take a 30,000-foot view of what I did well and what I didn't do well, and how can we help you in your day-to-day operations, not only operationally but strategically as well. And whether it's fair or not, outcomes are not based on the care provided to the patient. The outcomes are based on the documentation of the care that's provided to the patient. If this were a real estate seminar, what would have you always heard about real estate? It's location, location, location. Well, in healthcare, right or wrong, it's documentation, documentation, and documentation. Because documentation drives what we do for a patient, what we did for a patient, and what we should do for a patient. So documentation is just critical, and we have spent so much time and money and effort to get the documentation right, and yet we have so many inconsistencies even after years and billions of dollars that the government has actually helped provide to do this. So what are administrators like myself thinking as we put all this together? Well, first of all, when you look at what you and I and everybody else wants in healthcare, there's four things we really want. We want unlimited access, we want high technology, we want quality, and we want low cost. And the big variable in there is quality, because quality is different to everybody. Sometimes quality is just having access. Sometimes quality is the lack of pain. Quality can mean a lot of different things. And so as administrators, we're looking for, how do we provide the best patient care available, but also it's a business. Healthcare really consists of two things, and I'll be a little bit philosophical with you, and that is healthcare is a business, and we all know that. But healthcare is also a ministry. You're dealing with people. You're dealing with people's emotions. You're dealing with providers' emotions, doctors' emotions, especially surgeons' emotions, because they all have great ideas and great intentions, and that is to provide great care for their patients. But yet they're burdened by the regulatory requirements of documentation and many other types of regulatory issues. So what are we thinking as administrators when it comes to these issues, which we actually talk about quite a bit? And we have to be collecting all the necessary information as due to document that care in order to achieve the appropriate reimbursement compliantly. And compliance is a big issue, and you see that written in many different issues, and you see things all the time about poor documentation or billing practices that leads to regulatory issues. And no, most people don't do that on purpose, but that it is an issue that we constantly think about. And yet, how do we be efficient in our coding and our billing process to eliminate all the time lost in performing those tasks? And a huge issue is cleaning up the documentation shortcomings And how have we done that for years and years and years? And I did it many times in every place I went. We always had to bring in people to help us clean it up on the back end until really focusing on the front end. And quite frankly, quality improvement that we started years ago all focused around doing it right the first time. And yet, with documentation, we still continue to do things much of how we did it 10 or 15 years ago. Go into a physician's office or go into a hospital, and 90% of the time, the first thing a physician's office will hand you a clipboard and paper. I've had 3 surgeries in the last year. Nothing severe, just some elective surgery. Most of that documentation is done on paper. Even at the hospital that I used to run, and we were fairly highly IT savvy, still a great deal of it being done on paper. So trying to get that clinical integrity and the billing and coding integrity together can be a very time-consuming task, and we keep trying to do it using old conventional ways. We try and educate our physicians, we try and educate our staff, and all that is very important. But if we aren't using technology to do that, it's just too complicated, and it changes constantly. Because in the end, what we really want is we want our surgeons and our nurses and our HIMs and our coding people, they're all on the same team. And yet we have a tendency to talk about them in silos. And what we really need to do is give them a sense of purpose in their work. And, of course, not knowing all of you that are on this call, especially as you look at, deal with different age groups of our employees, what we really want is we want loyalty from those employees. We want them to feel like they have purpose in the work that they do, especially with millennials, because that has been proven that that's important to people. And so we have to provide them with the ways and the technology to do this so that it really is a win-win for everybody, and most importantly for the patient. And it all comes down not only to documentation, but to communication. How do we communicate what we have done to a patient to all the appropriate people, not just for financial reasons, but for clinical reasons going forward? And just to give you an example, if you were to look up articles that have been written recently, I can tell you of one hospital, a major teaching facility that is a top 100 hospital that just had their Medicare reimbursement cut because their infection rate is too high. Now, this is a great hospital. I happen to know the organization. Is their infection rate really too high, or is their documentation of the infections not appropriate, and that has led them to losing 1 or 2% of their Medicare reimbursement, which is real money to any healthcare facility. So those are the things that administrators, part of the things that we think about is how do we provide that technology and those processes that really bring everybody together and align those incentives. So then we talk about operational versus strategic thinking. Let me again step back a little bit, and again, I've been around for a long time. But back in the day, and that day isn't that long ago, if you wanted to do something, there was always one person in administration that the CEO used to say no, and that was usually the CFO. If you wanted to spend too much money and you wanted to buy new equipment or new technology or whatever, you kind of had to get it past the CFO, and normally their nickname was, oh, that's the person that's going to say no, because they're a little bit skeptical. And that was just stereotypically what we did. And but we've transitioned some of that, quite honestly, to the CIO. And that's not fair, and I will tell you as a CEO, we did that, not intentionally. But when you look at our budgets, I remember when your IT budget was maybe 1 or 2% of your total operating budget. And then, technology started to take off and it became 3 to 5%. And now it can be 8 to 10% of your operating budget because technology is changing so much, and everything we do focuses around IT. A silly example, if you take a colonoscopy, a piece of equipment that does your colonoscopy, the dishwasher that takes care of that is an IT product. It is linked into your healthcare system, and the CIO has to be involved, and IT has to be involved in implementing that dishwasher. That's how much pressure we have put on IT. And so it's very easy to say no when someone presents something that's a new system or a new installation, because resources are obviously scarce. But at the same time, as CEOs and CFOs and others are trying to think, how do we get past the next month? How do we look at how we do the next month or 2 months or 6 months because our budgets are so tight. And yet versus that 3-year mentality which says strategically, where are we going to go? Where are we going? And technology is such a major part of that and should play a major part of that. And if you think of surgical procedures, just as an example, and that's what we're talking about today, oftentimes surgical procedures can represent anywhere from 60 to 65% of the total revenue of a hospital or a health system, because while an inpatient admission may get you a few $1,000s, a surgical procedure can get you tens of thousands of dollars, especially if the documentation is done appropriately and done right the first time, not only on the hospital and the technology side, but on the physician side and the professional side, which as I'll discuss in a minute. Those lines are being narrowed because so many physicians are now employed and are part of that health system. So the question is for a CIO, who we put a great deal of pressure on, and the coders and everyone else, is are we driving towards our vision and our mission statements, or are we just driving towards a destination? And it's not about a destination, because we'll never reach that destination. It's a journey. The more high-tech we get and the more processes that we solve, there's another one right behind it. And that will never change, and that's a good thing. That means that we're constantly looking to improve our healthcare system and to improve how we take care of people. Because if I were to look at your mission statement or your vision statement, depending on what your hospital or health system does, there's several things I could probably tell you without seeing them that are on there. And first of all, you're probably talking about healthier communities. You're probably talking about managing the health of a population, and you're also talking about high-quality, low-cost health care. Everybody talks about it, and yet we don't know quite what all that means, but we have created a tremendous amount of documentation technology. We have EHRs, we have primary care portals, we have hospital portals, we have physician portals, and guess what? None of them talk to each other. And how do they communicate to those care teams? And some do a pretty good job, but for the most part they don't. It's not a criticism, it's just the nature of where we are in that destination right now, but the journey is going to be much different. You're going to see much blurrier lines between the silos that we've created. And when you look at a hospital and a provider office, and that's lots of providers, that's not just the surgeon or the primary care, but that's your surgery center, that can be your home care, because if those things don't go well, everyone may pay a price for that, economically or from a quality standpoint, but if we do it well, then everybody wins, because even though we focus on volume to value, we're still going to get paid on a volume basis for a long time, and we're going to get paid on quality issues and what is real quality. So we want to we really want to break down those silos, because in the future, as you see more consolidations, not only between what you see hospital and providers and surgery centers and others, but the payers as well. And the payers are looking for, how do we do this in a way that allows things to change quickly and to change with the regulations and to change with our changing population. We've got a lot of baby boomers, and you've all heard this, that are retiring, but you also have different groups, and we're still seeing a lot of disease process. And if we don't get the care teams aligned and together, managing that population is going to be very difficult. So that's how we can use a solution such as Nuance and Vincari to do this, and to use technology to do that allows the doctors and the caregivers to do the documentation they need, to push data and push information and to push those regulations in front of them, because as we say, all those people know the answers. They know, they've got it right in their head. They know the answers. They don't know the questions. And when you're talking about 140,000 questions, they can't be expected to know that. And then to take those answers and get them to all the appropriate people involved can be significant in not only the financial health of an organization and to help with that reoccurring operating income. In fact, that's what, whether you realize it or not, that's what your CFOs are looking at. They're looking at how are we doing from a reoccurring operating income standpoint, because net income is important, but it relies a great deal on investment income, and some people have it, some people don't, and you can't rely on it. And so that reoccurring operating income and how efficient you are, and that crosses many different lines, is extremely important for your financial success. And hopefully if you're successful financially, then you've got the resources to use those systems and that technology through artificial intelligence and the things coming down the pike where you won't have to reinvent yourself every time something comes. It's just another way that you extend and expand your journey down to what your mission and your vision stand for. So that's what Nuance and Vincari allow you to do in a way that's very different and allows you to distinguish yourself from where you are now, and quite frankly, distinguish yourself from competitors. And that's what we're looking at. So with that, I'll turn it over to Michael, and he'll be able to talk with you with some of the results of what's going on and poor documentation, and to show you, a great solution.
Thank you, John. So as we've mentioned a lot of different things, and Karen at the top of the presentation really brought up those three main issues that we're trying to address. And if we knew that if we could address those issues in an efficient way, there's a lot of downstream repercussions of that as well. Documentation obviously is important for the communication for the ongoing care, but we know that almost everything at the hospital or at the surgery center or at even the physician's office is very tied to the quality of documentation that is done. So this is obviously a lengthy list of issues that come from poor documentation. And we're not saying that every facility has every single one of these, but almost all of them have a different combination of some. And so with Vincari and what Nuance have tried to do, again, is that to provide a tool that is going to assist the surgeons with the documentation to ensure that the right information is captured the first time. So when we talk about adaptive capture, what we mean by that is the physicians must have a tool that, as the CMS rules around documentation, or just as the rules around documentation change, that information needs to update in the physician's tool so that it's not a sticky note in the dictation lounge or a query back from a coder after the fact, or a classroom session that surgeons most likely are not going to attend to try and learn these things. It needs to just help the physician through that to make the physician more efficient. Secondly, when we talk about leveraging intelligence, as some people have called us a bolt-on system, if you will, but to be an efficient bolt-on, you have to be able to pull information from that parent EHR, leverage things that the physician has done in the past so that they're not re-documenting a lot of the same techniques and things that they spend a lot of time regurgitating dictation, but also allow them to keep that patient context and really that specific patient story. And then lastly, once you've pulled that information and made it better, we want to try and get this information back to those different systems in an efficient way as well. So that whether it's to the provider's office, having that CPT, ICD-10 diagnosis information, as well as that operative report immediately back to my office as a surgeon, whether I'm no matter what facility I'm operating at, that obviously is extremely important in closing that gap so that I can get my billing out. It's obviously extremely important to the facility that their EMR has the best information possible in it, and in it at a timely manner, so that before the surgeon is talking to the family, that operative note is in the EHR. It's available to the recovery room for them to have that note. It's not handwritten scribble that we all see from surgeons as well. And the last piece really is that if we can solve those three issues and give the physicians the tool that's going to learn what they do, give them guidance, and push that information back, we start to see those documentation downfalls. We start to see those things correct. And at the end of the day, if you create the best tool in the world that surgeons won't use, then it's all for naught. So everything that has gone into this product over the last decade has been really a direct result from the surgeon users that use it and the administrator and coding and CDI teams that rely on the data that we're pushing. I've worked with many different CDI teams and HIM departments as well. And when they mention, a lot of CDI folks spend a lot of time and focus a lot of their attention, as they should, on the inpatient stay, with the hospitalists documenting a lot of the H&P's progress notes and some of that, whereas they don't spend as much time doing improvement around what happened in the operating room. So Vincari, from the words of a CDI specialist that I've worked with, is that this really works as an electronic CDI specialist that's sitting at the shoulder of the surgeon as they document. Again, just to try, which you'll see in the demo, but to try and make it as easy for both the CDI team, the HIM department, and the surgeons, so that, no CDI team likes to butt heads with surgeons. The surgeons, they obviously want to give the best information they can. And so we believe that a tool is really the best way of doing that. So the next piece before I get into the demo is really the how the system connects. So in the past, it really was, and through all of our clients we have today, we have interfaced with almost every large EHR system out there, and as well as some even homegrown systems as well. We did that through a lot of standard HL7 interfacing, and a lot of these interfaces that exist already at your facility have the ability to be cloned or sent to our system for the IT light scenario, meaning the implementation of this is usually fairly simple. However, in the future, and what we've done now is working with more of the APIs and the Smart on Fire, if your protocols, if you're familiar with that, but it's really more of this App Store approach, which we are on the Epic App Store, and we're working on some others as well, to make that integration a even easier thing for IT to say yes to, and make those systems talk and break down as many silos as possible. So through the Epic APIs that we use, and in this screenshot that you see to the right, the workflow is actually within that parent EMR. So whether I've chosen my patient and I click Vincari from the list of my tabs and then begin the report, to the surgeon, I'm just using a new app within that system that pulls existing diagnoses, maybe from the problem list, pre-op or procedures that are scheduled for surgery, we're able to leverage through that scheduling feed, and then pushing the data back into the EMR in the form of discrete information that can be updated into its specific spot, as well as providing that PDF of the final report for human consumption, if you will. So we can talk more on specifics, but again, that's really how this has been designed to plug in to these different systems. So with all of that being said, let's take a closer look at how the application is actually used. So in doing this, I'm going to take the first example. Let's assume that I'm a general surgeon. I've just completed, let's say, a lap chole for acute cholecystitis. I have to create my op note. I'll do that through Vincari, again, from within that parent EMR. And then the second time, I'll step back through and go much slower so that we can dive into some of the details. But I wanted to walk through it quickly, not to confuse anyone, but to allow you to see how surgeons are able to complete this full op note on average in less than 90 seconds. So Karen, I'm going to let you confirm that you can see my screen here before I start.
Okay, Michael, looks good.
Okay, great. So for this workflow, again, I'm within the Vincari application here, which is web-based application. But again, I can assume that I've chosen sample patient from within my EMR and chosen Vincari. and then I'll hit begin report. So when I hit begin report, it takes us into the actual report generator, and I'm basically walking down this left-hand nav to create this full operative report using these visual cues. So because I've used the application, I'll go up to my custom reports list, let's say my lap chole acute, and when I choose that, it's going to fill out a lot of the pre-op procedure performed and some of the other items that are not going to change. Although I could change them. But notice with my yellow triangle, gallstones and the way I've documented is not specific enough for ICD-10. So instead of having to memorize what the question is, here's where the application is going to just prompt me for that information. Okay, simple enough, without obstruction. The system does offer for certain diagnoses the way for me to use this visual documentation in the forms of images and diagrams. It's not mandatory, so let's go on to next. A lot of times post-op is the same, so I can copy over my pre-op. My procedure performed is there. My assistant was my assistant that's there. Let's choose on anesthesia. Notice anesthesia is not required for that Joint Commission so it's not a yellow or a red check, but for here I'll work down, say blood loss was less than 5, and that for my findings, notice from my list, it's learned different things that I have a surgeon have added for this procedure in the past, or I can use my Dragon Medical One to actually dictate into any of these fields as well. So for this one, let's just say inflammation of gallbladder, specimens removed was gallbladder, my indications. Notice this leveraged from the EMR, my patient name, age, sex, some of my common indications I may use for this procedure. Again, I can add using voice to text any additional information as well. For my technique, notice here, I have got my standard technique for this procedure. We know not every lap chole is the same or colectomy or cabbage, but if I start having this as my starting point, I can edit. And I also have the ability to save as many different versions of this procedure as well. So by choosing my lap chole acute, it's got my information in there. At that point, if all required fields have been filled out, I choose eSign. That note is automatically sent back into Epic or into my parent EHR. It's automatically sent back to my office, which we had configured on the back end, which I can show a little bit more, but my office has immediate access to this as well. And they also have immediate access to this charge report. So we see a lot of different workflows for surgeons post-operatively, whether it's handwriting a post-op note, then dictating an op note, then filling out filling out that charge report or an index card to deliver back to their office. This is really designed to kill all three of those birds with one stone. And by simply documenting my op note and collecting that information through the process, I have, again, created that final op note that is e-signed and ready for billing immediately. It's also going to track all of my cases as well. So I just performed this lap chole. That's one for today. As I do use Vincari over the week, over the month, over the year, I'm able to then export this data so that for recertification or for research, I have a list of all these procedures. Now, we know that you can dig that out of Epic or out of the EMR if you contact the facility, but this gives you as a physician another place where it's really tracking your items as well. So I know I walked through that one fairly quick. I'm now going to jump back into one more example, and I'll go a little bit slower and kind of build that note from scratch so you can see that. So I'm going to choose my operative report, say begin report. So as I mentioned, this has been designed to flow in the same way that the surgeon has been documenting their whole career. The application in its original design, we knew it needed to be intuitive. As CMO mentions, really, he calls it software for dummies, more or less because surgeons, they did not go to medical school to learn how to dictate or document. It's really the last thing is a task. So we wanted to make sure the tool was as intuitive and followed their thinking process as possible. Now, starting on the pre-op diagnosis, notice it's learned that I previously documented this on this patient. This also is an example of how if a diagnosis exists within the EHR, we can leverage that information into this pre-op diagnosis section as well. So if it's something that was on a problem list, I'm able to leverage that data here as well. For this example, let's say cutaneous abscess. So for ICD-10, if the diagnosis is not specific enough, again, the surgeons know the answer to the question. A lot of times they just don't know what the question is. So by just simply answering it was on the trunk and then it was on the back, by answering those two questions, I've navigated several pages of a coding book, and that's another thing, that surgeons are not coders and we don't intend them to be. But we do want to give them the language that the coders and people downstream are looking for, so that if you say, it's on their body and it's, towards their back or something along that, that path, that the coders aren't looking into it saying, well, did he mean it was on the trunk and the back? Again, simple example. It gets more complicated with other diagnoses, but we want the physicians to capture that language as well. So post-op, again, same. I can add as many diagnoses to this as well. And this list learns what this physician, this general surgeon, has done most commonly in the application. So when we talk about leveraging that intelligence, it really needed to learn the habits of the surgeon so that, again, you're as a creature of habit, again, that quote from many physicians we work with, we want the application to learn what you're doing. So next, based on the diagnoses I've selected, I've got my procedures that are related. So let's choose excisional debridement. And where lap chole didn't ask me any additional questions, excisional debridement is at the other end of the spectrum. This is a highly RAC audited procedure, mainly because of the complexity and all of the different requirements that the coders and such are looking for appropriate reimbursement. So whereas this one asked 5 or 6 questions, let's say it was on the right side, again, of the back, it went into subcutaneous tissue. The total area was 25 centimeters. We removed some necrotic tissue. I used my scalpel. Beforehand, it was 5 by 5, and after I debrided it was 5 by 6, and I used some gauze. So again, by answering each one of those questions, those are really representative of a potential query if I don't answer it now. Now, again, this falls anywhere between 0 questions to a procedure like excisional debridement where there are multiple questions that need to be answered. Now, if it's like a total hip and I do cement every time, I always use, with allograft or whatever, I have the ability to save that combination so that I'm not having to every time click through each one of those, if it's something I do commonly. So we obviously take all that into account. So the general information, this is really where I'm adding the other required fields like assistance, blood loss, specimens removed, and so on. I have the ability to customize this, add blood loss, drains, sponge and needle counts, other items as well, such as complications. So, and each one of these is going to learn what you have used in the past as well. So again, Dr. Jones was my assistant. It was less than 5. We removed some necrotic tissue. My complications, notice this is a list that I can say that there were no complications, but if there were some post-procedural complications or there was something acquired during the procedure, this list is actually a codified list as well, which is fairly new. We're starting to adapt that a little bit more. That is a big focus right now, as it's something that our customers have mentioned a lot recently. So capturing those complications. Anesthesia, as I mentioned, let's say general, and move on to technique. So the technique page is really where we allow the surgeon to keep that personal context and to save their narratives, if you will. So those first 2 modules are really around capturing that structured information, codified information for procedures and diagnoses, as well as the blood loss and some of the others. Technique is really more for my narrative. So as I mentioned, by using Dragon, I can easily dictate into here. I also have the ability to save as many different indications as well. So this is just a standard indication, but we mentioned, I have orthopedic surgeons that are doing total hips that they may have a whole paragraph here talking about failing conservative treatment, and all these different requirements that if you're not careful, it's very easy to leave out of the dictation, especially if it's late at night or you're in the car trying to dictate on the way home or something like that. So again, being able to capture that information is important. And then between the findings and my technique, here's where surgeons a lot of times would say, okay, well, you can't templatize what I do. And that's because in the past, a template would mean you'd need 1,000 variations to make sure that you had all the different findings you could possibly have, whereby using an application that's leveraging different sections of your dictation that may remain the same, the findings allows you to focus on what was different. So here by choosing, large cutaneous abscess, again, I could then click in there and dictate a whole array of different findings and things that made this excisional debridement different than the last one I did. By doing that, it allows me to eliminate what I'm focusing on prior to the procedure, the risks and benefits and alternatives are discussed and agreed to proceed, all full, that dictation that you may be doing, but making sure that that dictation or that technique still is consistent with the case that just happened by leveraging, again, the way I answered those questions earlier. Physicians also have the ability to create their own drop downs in here so that it allows for more one-off type things. And as I mentioned, you can save as many different versions of that procedure as well. Moving on to the risk factors, this is, in the past, a lot of surgeons will say, well, I'm not necessarily treating their diabetes or their heart failure. Whereas if you're putting the patient under anesthesia, as the surgeon, you really are responsible and you are being graded on how sick that patient actually is. So yes, you could rely on others and hope that that documentation is done, or you can make sure that you're capturing it as well, which Vincari leverages this data. So diabetes, hypertension, gout, whatever that may exist in the chart can be pulled into here, so that if diabetes lives in the EMR as diabetes, this is one more opportunity that I would see the yellow triangle and be able to give a little bit more specificity on what that may be. Again, not required, but as we see physicians and hospitals and surgeons being graded on this information even more, we know it was important to give physicians the opportunity to do that. The associated providers, this is where I was talking about on that pre-configuration. So everyone, say my office, that would have been automatically pre-configured, where every time I e-sign this note, it's automatically sent back to my office. Currently, it's through eFax. We're exploring with other EHRs the ability to be able to push back to some popular office EMRs, but currently this is a faxing capability, and again, it's sent immediately on e-signature. We also leverage Epic's distribution channels or your parent EHR's distribution channels as well. So if you've got all of those rules already set up, if the physician chooses that they want the primary care physician to be CC'd, which that would be pulled through already if this was a real case, then once they e-sign it, then it's like they dictated it and said, CC Dr. Jones and your HIM department can distribute however they need. On the charge capture, this really is based on the documentation that was done. The Vincari rules engine is looking at the way that those questions were answered to generate a CPT and an ICD-10 code, mainly geared at sending it back to my office for billing. Most specifically for the office, mainly because at the hospitals, our clients mostly have said, what we really need is the excisional debridement with all of those questions answered so that my coders can do their job. And so that's why obviously you at the facility have access to the charge capture report, but the op note that comes out the other side, they're two different reports. So you can kind of, you can discount it, or again, from my private practice office, we see that as one of the huge value adds that surgeons recognize that their office having access to that. So if this was something that I did do commonly, let's say obviously my post-op may change, at that point, I'm able to save this as a custom report for myself, which would then come up into my list so that I could recall this with that one click and then make my post-op, my findings, and the blood loss and things that change make those changes. So that's really how we're addressing that and making that quicker, and how a physician would actually set this up. To touch lastly on how they set this up, our implementations of this product is also a little bit different than most, in that we don't hand the facility a bunch of usernames and give them and say good luck to the surgeons. We actually send representatives on site that work in the operating room with the surgeon, either in the recovery room or in the dictation lounge or in the physician's lounge, so that as they complete cases on day one, we're completing those through the application. It's starting to learn their habits, and then it grows as a snowball from there. And so it's not necessarily sit down and train your surgeons how to do this in a classroom and then send them on their way. We really work with them for those first few cases. And then I'll sign that note, and it's available back into the EHR and elsewhere. So I know I just did a lot of talking. Karen, I'd like to open it up and we can address any questions that have come in through the Q&A.
Sure, absolutely. Thank you both. So what you can do is go ahead and click on the Q&A button on the bottom of the console and submit your question, and we'll take those as they come in. So while we're going through that, I have a question for John. I'm going to make sure your phone's on mute. So one of the common objections that we hear in the field is, will my surgeons actually use the solution? And what has been your experience, and what's your response to that?
Well, that's a great question, and that is a concern that usually when you do you introduce something like this, what you hear is, my surgeons will never use this, and sometimes even from surgeons we've heard things like, I've been dictating longer than you're alive, and things like that. And yet we have about an 87% adoption rate, voluntary adoption rate by the surgeons, that's one area of concern that you would think would be a major concern, but yet it turns out that that's usually not the issue. The surgeons really enjoy using this because they don't like to dictate, they don't like queries, and they don't like all the process that they have to go through that we've actually been putting them through for the last 30 years. So our adoption rate has been exceedingly high, and that really hasn't been a major obstacle at all.
That's great, thanks. And then maybe to add to that a little bit, talking about the return on investment to the organization and to the physicians themselves, could you talk a little bit about what you've seen with our clients around freeing up unbilled surgical cases and reduction in DNFB and that immediate impact, and what has been your experience with that?
Sure. Well, it's interesting that one health system in New York we were talking with the physician's office, and we said, how long does it take for you to get that op note and that information back to your office so you can begin the billing process? And the answer was 7 days. And of course, I was kind of like, 7 days? And they were like, yeah, and that's pretty good. And I said, well, what if we could make it 7 minutes? And it's amazing what we put up with because of inefficiencies. And so, first of all, for the private practicing physician, but also put this in the perspective of your health system that employs many, many doctors. We know that employing physicians, and I have employed hundreds of physicians in my career. I enjoyed it. They are so important to our health system, but very expensive because of all the overhead that they bring with them. And yet, when you talk about the inefficiencies that they have in their office, and that they can do a surgical procedure, they can complete their op note. That op note can literally be in their office, in a private practice physician that can be in their office in a matter of minutes, so that their office coder, with the suggested codes, can code that and bill it as fast as she can code it and bill it. So if she can code it and bill it in 3 hours, it's out the door, and the reimbursement can get on its way from the payer. And I've talked to real-life coders and office managers that are using Vincari. And the other thing is that you have a standardized report. It looks the same. It may be a different procedure, but it looks the same, so they know right where to go to find that information. Now, extrapolate that if you were a health system or a hospital that has hundreds of doctors, and those op notes all look the same. meaning it's the same format. They know where to find the information. They've got the suggested codes, and they all have it very quickly. Think of the difference that can take. I can tell you that on any given day, it is not unusual for a medium-sized health system to have millions of dollars, and I am serious, millions of dollars in the queue waiting to be billed, waiting for all the documentation to get completed. Anecdotally, one health system that I know very well, on any given day, they have $4 to $7 million waiting in the queue to be billed, waiting for the doctor to complete their documentation, the coders to code it, to go through any inquiries. Although queries have gone down to a certain extent, but it is just amazing how much money we leave on the table and how much time we leave on the table because we're not using this type of technology.
Thanks. So when you look at that and when you consider the impact on the organization, evaluating a solution like this is really more of an operational expense when you think about it, as opposed to a capital expense in terms of freeing up resources and moving cash through the organization more quickly. So maybe just a little bit of experience or perspective on that.
And that is absolutely true. There's almost very little, if any, capital expense, and we all know that capital is very difficult, and there's years where there's capital is pretty available, and a lot of years when it's not available, and that's why that, and I talk about it, that's why that reoccurring operating income is so important, because if you're relying on investment income, you have a bad year and all of a sudden there's no capital, and I've been through that with our health systems, and you don't have any money to spend on capital. This is pretty much purely operational expense, and as the saying goes, cash is king. That's why the difference in healthcare, which is very difficult, we're very different than any other business out there. You can sell every bit of the product you have, be really busy, and lose your shirt because of your payer mix. And so that's why it's so important that you don't leave anything on the table. And if you can enhance the cash coming in, that is huge, and that makes all the difference in the world to the bottom line. And it can have significant impact on your AR as well.
Sure. Michael, this next question is for you. So considering that keeping up with the constantly changing regulations is really difficult for everyone, what is our perspective and approach on how we help make sure that the system's updated and that the very latest information is available to surgeons so they have everything right there and it's easy for IT teams to keep up to date?
Right. So we have, the application is web-based. So even if it is being accessed and integrated into a parent EHR, we still have immediate access to be able to update this data at any point in time, which typically comes quarterly. So, or whenever a new batch update of all these coding information or coding changes is there. We have an entire data team on our side that really is one of our differentiators, again, in making sure that that information is most up to date. We have several consultants as well that help guide us to make sure that we are asking the best questions when a certain procedure is chosen in the application. Again, that comes from several experts, and mostly around CDI, that we have helping us guide that. So the data team, as they keep that up to date, if let's say I had that excisional debridement, just because it was the example I used, saved as a quote template for myself and Vincari, if they add a new question or a new requirement for that procedure, when I load that template up next time, I'm now going to have a yellow triangle for that question for me to answer. Where if I'm using, if I'm using another application or a template, the old-fashioned form of a template, those are not dynamic and can oftentimes balloon into something unmanageable. So by managing the data on the procedure and diagnosis level for certain requirements, that's really how we remain adaptive and how we're able to keep up quarterly with the changes as they come down the line.
That's great, thanks. And this one is also to you. Could you share with us a little bit about how long does it take an individual surgeon to get up to speed? What are the different ways in which you approach implementation based on different technology awareness levels and different abilities to use the system? How do you personalize that approach? And how long does it take to help build their templates and so forth so that they can get up to speed in using it?
Yeah, so I'll kind of take it from the beginning of, let's say a customer said, you know, this looks great, Vincari's the direction we want to go, let's start going. From that point, it's usually about 3 to 4 weeks that takes us in a discovery phase for the integration and making sure that the application is going to be accessible at the go live date, which is the day we turn it on to the surgeon. So that's usually about 4 weeks after the facility agrees to move forward. Once go live, during that discovery phase, if a physician already has templates that exist, some of them have a few that HIM may have in their toolbox, we're able to gather those and go ahead and upload those into the system for those who already have some templates. So we're able to get that accomplished. And then after go live, as I mentioned, we actually have reps that are floating around the facility and are aware of the high volume traffic spots for surgeons. We have a brief awareness campaign before go live that just makes the surgeons aware that we're coming. And then based on, we have some physicians that you give them their login and they don't need your help anymore. And then you've got that one doctor that HIM basically warns you about, and they kind of chuckle and they're like, good luck with Dr. Williams. And we see from any of that range, especially with the Dr. Williams, if you will, quote, it's really anywhere from 3 to 5 cases. And the reason I say 3 is that if we can get that Dr. Williams to agree to just trying the application with us for 3 cases, typically they're going to recognize where it saves them in that redundancy, and the light bulb really kind of goes off at that point. So anywhere between 3 and 10 cases, we have the physicians, they know the workflow, they understand how to access it, and they understand how to, hit save on something that they know they're going to do again. And we're on site typically for 2 to 3 weeks after go live, working with physicians back in the OR. So that's kind of how that process works. And as John mentioned, our adoption rate, just like any other implementations and such, we have our incentives for our reps to make sure that we're getting as high an adoption rate as possible. And so therefore, if they warn us about Dr. Williams, we don't go sit in the corner and hide from Dr. Williams. He bubbles to the top, and it's almost one of those that we make sure that we get those 3 cases with. And also, every facility has. Okay, yeah, go ahead.
No, that's fine. I was just going to say it's a very personalized approach. So we've reached the top of the hour. As you can tell, we're really passionate and excited about the solution and the outcomes that we can help enable your organization to achieve in terms of improving physician experience. We would love to continue the conversation with you. If you'd like to reach out to us, our contact information is here on the slide. Shortly after today's session, we'll package up a copy of the slideware as well as a recording of the presentation and make that available to you as well to share with other members of the team at your organization. So again, on behalf of Nuance and Vincari, I'm Karen Landon, and on behalf of Michael and John, thanks again for your time with us today, and thank you for sharing your afternoon with us.